Hello, my name is Dr. Mark Harmon, and I'm going to give you a quick lesson about Cushing's disease and/or syndrome and obstructive sleep apnea. So first, let's ask the question: what is Cushing's disease, and what is Cushing syndrome? What does that mean to us? So the disease is fairly straightforward. It's an endocrine system disorder. Where there's a number of kind of symptom clusters, and the syndrome is as we'll see a little later on, the disorder, but caused by different reasons. And so for the disease, because it's an endocrine disorder, it's usually more of like a cancerous disorder, whereas the syndrome is actually the name for anything that would cause excessive cortisol in the body that would result in similar symptoms as Cushing's disease. So let's first just look at the general endocrine system, which would look at both the disease and the syndrome. So here's how the body normally works. There's something called the hypothalamic pituitary axis. It's also known more simply as the HPA axis. And so what happens is, as our body has stress, disease, there's other things that happen, it produces a reaction in the brain that will go to the hypothalamus. The hypothalamus will then basically stimulate the pituitary gland, which is this small area right here. It's kind of the hypothalamus here, the pituitary gland right down there. And what that does is the hypothalamus, once it stimulates the pituitary, the hypothalamus itself will release a substance called a corticotropin hormone. So whenever you hear the word tropin, I want you to think makes or creates. That's what tropin or trophin means. And so it's a hormone to make cortisol. Well, that hormone doesn't directly make it. What it then does is it actually stimulates the anterior pituitary, which is this area here. As you can see, we're doing here. So CRH is secreted from the hypothalamus. It then travels down this line and then goes to the anterior pituitary gland, which is the front of the pituitary facing towards the eyes. This actually stimulates something called ACTH, which the real word is a pretty big mouthful. It's adrenocorticotropic hormone. That's just a very kind of long scientific way of saying send it to the adrenals, which the adrenal glands sit right here on top of the kidneys, and have the adrenals make cortisol. Because cortisol is actually created in the adrenal glands, which are outside the kidneys. So what we're seeing is, and this is why we see more of the kind of general body symptoms that we'll look at here in a minute, is even though the hypothalamus, which is in the brain, as well as the pituitary, are the ones initially stimulating it, these hormones, particularly ACTH, have to travel through the body via the blood vessels. So it's going everywhere, arms, legs, stomach, everywhere, to actually get to the kidneys and the adrenal glands that sit on top of the kidneys in order to start creating the cortisol itself. And then that cortisol, again, begins to be circulated throughout the body. And there's a number of complicated reactions which kind of balance and help these, but we just want to kind of concern ourselves right now with the basic pathway, which that name for the pathway again is the hypothalamic pituitary axis, very most commonly known as HPA. Okay. So let's keep moving a little forward. So what are some of the general symptoms? So if you have a Cushing's disease, this system that we've talked about, it basically gets completely out of whack, and it begins to hypersecrete all of these things. And the origin could be here, where the hypothalamus is creating way too much CRH. It could be more likely the pituitary, which creates way too much ACH. Or it could actually be a problem in the adrenal glands itself that are causing a hypersecretion of cortisol. And what you'll see a little later on is when you talk about the disease is actually a problem here in the pituitary gland. When you talk about the syndrome, it's usually actually a problem here in the adrenal glands or something that's acting directly on those adrenal glands. So for the symptoms, when you're looking at Cushing's, one of the first things you begin to see is you begin to see a large amount of weight gain. And whether this is the syndrome or whether it's disease, the symptoms are fairly similar. We'll see a little later as we get a little more granular how to differentiate between the two. But for right now, let's just know that this goes to actually both disease and syndrome. So there's weight gain, but yet the arms and legs become very thin. So what we call this is these two together are called truncal weight gain, meaning you gain a large amount of weight in the trunk area, but your arms and legs actually begin to thin out, and you become very thin in the arms and legs, but you have a large abdominal, chest, back, and neck and head area. The other one common is what's called moon facies, which is a very, very round circular faced face or head region. You also have what's called a buffalo hump. And a buffalo hump is exactly what it sounds like. When you look at a buffalo, right behind the base of the neck, there's this large kind of hump area. And so what you see with someone with Cushing's disease or syndrome is you'll actually see their head begin to protrude forward a little bit, and you'll begin to see this hump of tissue that's developed on the back of the neck. Another common thing that you see and hear about is that they bruise very, very easy. So the lightest bump or touch tends to cause bruising. And finally, we're going to look at something called abdominal stria. Abdominal stria is what's called pathognomonic, which means once you see this, you just immediately start thinking, I need to identify, is it Cushing's disease, syndrome, what is it? And I'll actually show you what that looks like in a minute. But that's kind of a cardinal sign. Finally, you start to have muscle weakness. You remember me talking a few minutes ago about how you have, kind of wasting away of the muscles in the arms and legs. Well, that also begins to result in having some weakness in the muscles itself and some neurological issues. So when we look at someone, so if you're physically examining someone who would possibly or does have Cushing's syndrome or disease, what do we see? What are the first kind of big things that we see to know what's going on? Well, the first thing we see and that we take note of, whether it's syndrome or disease again, although these tend to occur and be more prominent in the disease than they do the syndrome, but they can occur in both. It's first is the stria that I talked about, right? So that's the stria. They're these dark pigmented lines that they tend to run along the stomach area, but you can see they occur around the breast tissue area, even the arm areas at times, particularly the upper arms. Second is you remember me talking about moon facies. Well, moon facies is just that. Notice how round the face is. It becomes almost completely circular because of fatty deposits that happen around the face. You also will see that the base of the neck itself is very fat or fatty, which is caused by a lot of fat deposition in the area. And this eventually does cause that buffalo hump that we talked about, where because the fatty tissue begins to concentrate kind of more around that area, it's what causes the what's known as the. So how do we tell whether it's a syndrome or disease? How do I know which one's which? Because the treatment will be very different depending on which one you identify that. And so first off, when we look at the disease, we look at three main areas or three main factors. The first is that the disease is usually caused by what's known as an adenoma. Right? And if you remember, previously I talked about the pituitary gland and the anterior pituitary gland in particular, which was where the ACTH was being produced. And so if you end up getting a small cancerous growth, that's going to cause a hypersecretion in that area. That growth is known as an adenoma. And so it's basically a cancer of the pituitary gland. Now, we normally hear the word cancer and we think, oh dear, this people are very sick, very, dying, that type of thing. Oftentimes you can have an adenoma. Some people don't even know about it. It's not even symptomatic, or if it is symptomatic, it's very light, and adenomas don't tend to grow very large. And if they do, it becomes very apparent because that area is such a small, confined space in the brain. It'll impinge on things like the optic nerve and cause kind of a eyesight to begin to double. You can actually see a deviation of the eye and things like that at times. But this is normally what it's called. It is an adenoma when it's in that area. Now, this is basically really the big definition of disease versus syndrome. If it's caused by an adenoma, it's Cushing's disease. If it's caused by anything else, it's syndrome. And syndrome is also what's known as ectopic, which is just saying outside of the area where it's produced. So it means either ACTH is being produced outside of the body, or I apologize, outside of the area of the pituitary gland, or which is a syndrome, or if it's because it's in the pituitary gland, then it's called Cushing's disease. And where it's an adenoma, it is an increase of ACTH, which is a activation of the HPA axis far more than it should or is normally activated. And this kind of just repeats the point I was just saying, which is that ACTH is that HPA part of that HPA activation. Now, if it's not an adenoma, and it's not from this kind of central ACTH production in the brain or the pituitary, then it's actually Cushing's syndrome. Cushing's syndrome, the first thing we know is it's outside the body. But the second thing, which is that the most common cause of Cushing's syndrome is actually what's known as iatrogenic. Iatrogenic simply means due to medical treatment. So it's actually caused by the medication someone is taking. For example, if you're taking corticosteroids, you can actually cause a Cushing's syndrome if it's not properly, if you've taken them for too long or too high a dose, or they have not been properly tapered off. So this is very kind of what's known as gender neutral. Now, when we looked at the disease actually, it's only prevalent in the population somewhere between 2 to 5%. But females between the ages of 30 and 40 are actually about 3 times more likely to get Cushing's disease than males. Syndrome, however, we see it's a completely gender neutral. Male or female are at equal risk at any time of getting it. And mainly that's because of this iatrogenic nature, where it's normally caused by medical treatment itself, as opposed to a dysfunction in the body. If it is a non-iatrogenic generation or generated, which basically only accounts for about maybe 20% of Cushing syndrome. Over 50% of the time, it's usually due to lung cancer, and specifically it's small cell lung cancer, which in and of itself can produce either corticotropin hormone or it can produce ACTH. And syndrome, in large part, we see because of cortisol. Now, if it's a small cell lung cancer, it could produce ACTH, and so even though it's a syndrome, but 9 times out of 10, what you see is it's a hyper secretion of cortisol, not a pituitary ACTH, or that ACTH, as I said before, is ectopic or being created outside of the brain or the. So let's look a little further at how, what's the difference? What do we see? Okay, so the dominant symptoms in Cushing's disease, as we talked about earlier, is that truncal obesity, the moon facies, the striaea, and then there's also something called hirsutism. Hirsutism is just a really fancy medical word for saying abnormally large amounts of facial hair. So women with abnormally large amounts of facial hair, and that is called hirsutism. And so these are kind of the dominant symptoms that you see. Now, when you're talking to patients, it's often called a history. So when you're taking a history, when you're talking to a patient, what are some of the things they say? Well, they talk about how I can just barely be brushed. and somehow I bruise extremely easily. They talk about how when they get cut, it takes a very, very long time to heal. And there's oftentimes they'll go through symptoms of depression with sleep disturbances, feeling depressed, feeling a lot of things. Something else that you see is that they have very brittle bones, and they tend to, the slightest hit will break bones. So they will have repeated histories of having broken limbs. So what about the syndrome? What do we see there? Is it the exact same? Not necessarily. You can see the truncal obesity, the moon facies, all of that, if they have had the syndrome for a very, very prolonged period of time, but it's normally caught much sooner than that. So normally what you see is you do see a lot of fluid retention rather than actual fat deposition. Someone who normally has good blood pressure suddenly has a very high blood pressure. When you take labs, you'll notice that they have a high amount of potassium in the blood, and they also often complain about having a hoarseness in their throat. So when you talk to them, what do you hear from their history? Well, it is slightly different. They talk about suddenly becoming short of breath, which is SOB. They talk about something called dysphagia, which is, I'm having a problem eating when I try to swallow, things like that. I just don't swallow as easily as I used to. I'm constantly getting choked, and I've never had that before. But then they also can talk about the depression and the easily broken bones as well. But you can see right there, we begin to see, even as we just talk to our patient, we can see how immediately we can start to think, okay, is it a disease or a syndrome? And we can follow that up with a number of lab tests and some other things, and even some scans to see if there's enlarged areas in the pituitary, or a chest x-ray for lung cancer and things like that. But that's where we want to start, is listening to our patient, looking at our patient, and seeing the difference between. So let's look very quickly at obstructive sleep apnea. So what is it? First off, what it is it's a repetitive episode of cessation of airflow, the cessation of airflow is known as apnea, and it's at the nose and mouth during sleep, and this is due because you'll see an obstruction. So normally this would not be falling here against the back of the pharynx. This would actually remain up slightly, and this airflow would just continually come in and out, in and out. Well, in obstructive sleep apnea, this becomes blocked, and the patient begins to have very difficulty breathing. Oftentimes will stop breathing for a prolonged period of time, maybe up to 5, 6, 7 seconds or longer. And then there's suddenly a large exhale, where the patient is actually in the sleep cycle has started waking up. Some other names for it, you might hear a Pickwickian syndrome. Some people refer to it as sleep apnea syndrome, or even nocturnal upper airway occlusion. But normally, more and more, we're beginning to accept obstructive sleep apnea, or OSA. And so we see this, it actually does occur more in males and females, which is the opposite of what we saw of Cushing. So that would be something that we immediately want to look at as well, because some of the symptoms, depression, hypertension, things like that, can overlap with Cushing. So we want to make sure to rule out each and which one is which. But you can see it happens in about 4% of males and about 2% of females. And it increases the more obesity you have, or the greater obesity, and the more hypertension you have, the more OSA risk factors begin to climb. So what's the pathophysiology? What causes this? It's just simply, as I said before, it's an obstruction or a very, very, very large narrowing of those airways in the pharyngeal area, which is kind of that back of the throat, lower throat area that stops. And so what do we see? What does the research tell us between Cushing's and obstructive sleep apnea? Well, in 1992, Shipley et al. Found that 32% of Cushing's patients are comorbid with obstructive sleep apnea. This would make sense when we talked about earlier the fatty deposition around the throat. That fatty deposition will add greater weight and will then close the airway, because you have to realize the pharyngeal area, the laryngeal area, it's a soft palate. So it's a lot of tissue. There's no bone, cartilage, anything to kind of keep it open. So the more fatty deposition you have there, the more weight that's going to close that tube while you're sleeping. Bottini and Tantucci in 2003 said the supposed weight gain in adipose tissue, which is what I was talking about just a second ago. They actually kind of hypothesized this is what's causing that pharyngeal collapse in Cushing's that's leading to a likely development of obstructive sleep apnea. And then in 2005, Buckley and Schatzberg, they actually observed that in obstructive sleep apnea, the HPA axis becomes hyperactivated. So obstructive sleep apnea can cause a Cushing syndrome, and a Cushing syndrome and disease can cause obstructive sleep apnea. They can go hand in hand, so we want to really start to kind of differentiate between the two. And in 2000, there was a relationship found between the suppression of muscle activation and hypercortisolism. So the more cortisone you have, or cortisol that you have in your system, the more your muscles tend to be suppressed, both sleeping and awake. In 2007, we also saw that Dadun kind of hypothesized that this sleep apnea syndrome causes that HPA axis, and officially kind of came down that's what he really thinks is going on here, and that between cortisol levels and other things, we see a lot of obstructive sleep apnea development. So thank you for your time. Thank you for your attention. And if there are any questions, I'll be happy to answer them after this. Thank you.